10 years ago, we did a massive screening campaign in France through the GPs and primary healthcare centers to try to reach the biggest number of people regarding their risk of having been exposed to HCV. We did a random screening in the people covered by the French insurance, the French national insurance. And that's how we got a pretty clear picture of the prevalence of hepatitis C in France, which is around 0.86%. A lot of those people could be involved in healthcare and have access to treatment. But unfortunately, in the smallest towns and in the oldest people, the ones who were most at risk of being infected with HCV, considering the time of exposure, we did not really manage to have a high rate of screening in this population. That's why we are still seeing old people arriving at hospital with decompensated cirrhosis of unknown origin, and it happens to be hepatitis C. So in terms of treatment, we have reached a quite big population, and we have seen through modeling that there is a real decrease in cirrhosis and HCC associated with hepatitis C. So it's quite a success, but we still have a lot to do, when we stop the campaign, the screening campaign, then the GPs and the doctors forget to screen, so it has to be repeated all the time. We follow about 3,400 patients. About 50% of them are gay men, because my hospital is located right in the center of Paris, very close to the gay area in Paris. And so the prevalence of Hep C is around 33%. And I'd say in the 50% of our population who is gay, the rate is reaching about 10 to 15%. And most of them were infected through sexual intercourse or use of recreative drugs, not only injecting, but a lot by nose, nasal route. So this is a very, very big problem. We've been starting to use those drugs for about a year, and we are using telaprevir more often than boceprevir, just because the course of treatment is shorter, so it's easier to manage side effects and drug-drug interactions with ARVs. So we have a pretty bigger experience with telaprevir than boceprevir. So what I can say about those treatments is, for now, we don't have a follow-up big enough to say if it's really effective. It looks like from the first results after 3 or 6 months of therapy that we reach a very high level of undetectable HCV RNA, but there are big side effects, particularly on the hematologic point of view. We have a lot of anemia and thrombocytopenia, so we use a lot of growth factors and transfusions. We don't have a lot of rash, and this is not the case for mono-infected patients. So in co-infected patients, it doesn't seem to be a big problem, but hematological problems are real issues for management. So we have to tackle with a lot of things, and the follow-up has to be really strict. It's called HyperGay, and it's sponsored by the NRS, which is a national agency for HIV and hepatitis. It has started a few weeks ago, and it's designed as a sequential trial, intermittent prophylaxis, especially on weekends, and then off for 3 or 4 days. The recruitment is being pretty difficult for many reasons. The first of all the reasons is that the patient, and they are not patients, they are people that have to go to hospital to be regularly checked once a week. So it's a very strong commitment. So it's pretty difficult to bring healthy people to hospital every week or every month or whatever. So this is the first obstacle. The second obstacle is that in Paris we are starting to see Truvada sold by the pill, and it costs about 25 euros. So a lot of people buy Truvada and they take the pill, and that's all. So they don't want to get involved in a trial. The people living with HIV come back to hospital saying, "Oh, we have lost our prescription, so we write another prescription." So they have 1 month of Truvada and they can sell the pills. So it has been reported by some patients that we are following in my clinic. So it's becoming a reality. This is the easiest to take, and this is the ones with less side effects when you take it on the short term. So I think it's a pretty good option if we think that PrEP is a good option. But we personally think that maybe by expanding screening, treating all the patients like TAS, treatment as prevention, it might be probably more cost effective than doing PrEP. That's my own opinion. And we really need cost effectiveness studies to compare PrEP and TASP and see what is sustainable on the long term.